Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19, infection control, and other nursing home-related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today's webinar is Sepsis Awareness and Early Intervention, Essential Training for Nursing Home Facilities. Everyone has entered the meeting on mute, but we will have a Q&A following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. We invite you to join us every Wednesday for more of our weekly webinars. Next week's topic is best practices for respiratory virus season. If you're interested in joining, that will be the same time and place next Wednesday at 2 p.m. Now I'll introduce our guest today, Tom Ahrens. Tom is CEO of Viven Health. He is a clinical nurse specialist with 35 years worth of experience. And Tom will kick us off, and then later on we'll be joined by Natasha Dickinson of Viven Health. Tom, thanks for joining us today.
Yeah, thanks, Kathy, so much. And thanks, everybody, for taking some time to join us. The topic, obviously, is sepsis, but this isn't a topic that ties right in with COVID. If I were to ask you how many people died of COVID, you'd find very large numbers being reported. But in all actuality, what happens is when someone gets COVID, they really don't die of the infection from COVID. They die of the body's response, which is what the definition of sepsis is. Sepsis is a fascinating clinical condition that we're still struggling to understand. And it's imperative that we do this fairly quickly because sepsis is probably the leading cause of death in the world. And it always starts with an infection. We have no real definitive treatment for sepsis. The best way to prevent sepsis is don't let infection start. So don't let someone get COVID because, again, it's not the infection that usually will cause a person to die or have complications. It's the body's response. And we're just going to take a few minutes and go through that. And then the other thing we're going to do is we're going to show you a program we've developed that's free of charge to you because of Quality Insights funding. And what we want to do is to show you how you can use this to educate your staff, the community, whoever you want. And the goal is not just to give content, as you'll see in our program. It's highly interactive, and it actually develops a little bit of clinical reasoning or critical thinking so that you can recognize when sepsis is present and when your resident is in danger. So what I want to do is go through just fairly briefly, and I don't like to give a lot of statistics because it's kind of boring. The only reason I want to show you this is to say that we have documented probably close to 2 million people a year get sepsis, but it's probably much, much greater than that. We have 250,000 people die of sepsis or more. But we know that sepsis is a leading cost in hospitals, which is one of the reasons why CMS is so interested in controlling this. Probably one of the most common reasons for our nursing home residents to be transferred back to a hospital is sepsis. It may be diagnosed as pneumonia or something else like some type of infection, but it's really sepsis. And you'll see as we go through this. It's actually fun to learn about sepsis. It's depressing to learn about treatments because there's so few of them. But the concept of sepsis is really fascinating. And this is a diagram from the Biomedical Advanced Research Development Agency, or BARDA. And not to go through this at all, the point being is that when sepsis occurs, the vast majority of it, about 80%, occurs in the community. And so people going into a hospital with sepsis actually acquired the infection and development of sepsis outside the hospital. And then the same thing can happen in a nursing home, is that you might get a patient from a hospital who might have a latent infection, and then the infection reoccurs, and then the person needs to go back to the hospital. But sepsis, once it starts, is extremely difficult to treat. And it can lead to organ dysfunction, shock, and obviously it can lead to death. And so our whole point of this presentation is to help recognize what it is, give a little background on sepsis, but then let's go through and show you really what happens. I want to show you I could do a whole seminar, a whole semester on the pathophysiology of sepsis. But what we want to do is just keep it very simple. And by doing that, you'll see why sepsis is so dangerous. I'd like to use this quote from William Osler. He wrote this 120 years ago. He talks about, except on few occasions, the patient appears to die from the body's response to the infection, not the infection itself. And that was very observant, considering how limited tools that he had to make assessments. But the point being is that what'll happen is the person might get an infection, whether it's pneumonia, whether it's a cut on the finger, doesn't matter. If you get an infection, you're at risk for your body's response. And the response is wonderful. It protects us all the time. But in sepsis, something goes wrong and it over responds. This is a quote from Lewis Thomas. I've used this for many years in my presentations. But he wrote about this in New England Journal of Medicine in 1972. And he just said, our arsenals for fighting off bacteria are so powerful, involve so many different defense mechanisms, we're more in danger from our own immune system than we are the invader. So that's what I was getting at. If you have COVID, then you're at risk for having an infection due to the virus. But that's not what's going to usually harm you. What's really going to harm you is your body's own immune system. And this is why, as we look to the pathophysiology of sepsis, if you understand some basics, it's pretty clear what happens. Let me just give you an example. So this is an illustration I'm going to show you of a neutrophil. This is one of our first and most important lines of defense. And what you're going to see is this neutrophil is going to chase a bacteria. And so let's just watch it for a second. The neutrophil is pushing aside red blood cells and is chasing this bacteria. And this neutrophil will never rest. It never stops until it catches the invader. In this case, it's probably a Staph aureus bacteria. And it'll shoot out a little pseudopod to grab it. It does that, then it pulls it inside of itself. And at this point, what it does will expose it to a vacuole inside the neutrophil itself. The vacuole has a pH of about 6, which is so low from a pH point of view, it will immediately kill the organism. See if we can show you another example here. This one here is an illustration. This is an animation. That was actually a real illustration of a neutrophil. Here's an animation that we have of something similar. So they're saying that, like, these are macrophages, these are circulating in our blood. They're always looking for something different. They're going to shoot out a pseudopod to grab it. And grab what's different. They're going to pull it inside of it. And if it's different, it's going to kill it. But it's also going to release cytokines. Cytokines are inflammatory mediators. And I'm going to show you what they do in just a second. But this is how we're going to control infections. And I'll show you exactly what happens with this here. So, and again, you heard music. There's no music in the blood vessel, so we wouldn't have that. But let me go through just briefly a few other things. How many of you ever dropped something on the floor and you were really hungry? Can you pick it up and eat it? And I know you're on mute, so you can just kind of answer this without really talking. But the idea is, if something drops on the floor, can you eat it? And that answer is, of course you can. But you're taking a chance, because as soon as it hits the floor, it's going to be contaminated. Now, our immune system is so good. Our GI system will basically lyse it as well. The idea would be is that things on the floor can be safely eaten as a rule, but I wouldn't say that's a recommendation I would give you. But if you have little kids or if you have little grandkids, you know what they do. They eat things off the floor all the time. We all did when we were young. So, and we did fine. So our immune system can handle most anything. It's actually wonderful about how powerful it is. And I'll give an example. This was my grandson, Sebastian, and we were in a park and he was riding his bike ahead of me, and I heard him yell to me. He said he found a binky. Well, binky's a pacifier. I thought, well, don't put it in your mouth. And when I get up to him, this is what he's got. He's got the pacifier in his mouth. And he knows I cautioned him against germs. And so he said, don't worry, I washed it out in this pool of water. Well, that was just a muddy pool of water. So even though he was trying to do the right thing, he shouldn't have put that in his mouth. But if you think about what happened to him, he's fine, and that had no problems for him at all. Again, I don't recommend you do that, but the point being is that our immune system is going to kill almost anything that gets into us. Now, here's the danger, though. Here's my granddaughter, Mia. So Mia fell and she cut herself. This is far more dangerous than that binky is. And the reason being is she's broken her first line of defense. And this is critical because now you've got something that's going to allow any bacteria that's on your skin to get into your blood vessels, into your bloodstream. And so once again, very rarely does this cause any problems, but you've increased your risk by getting a cut. So we have to clean these, have to make sure as much as possible we keep them from getting any other contamination. But a cut is much more dangerous. So any infection is potentially a problem for us. Now, let me just walk you through what happens in an immune system response. And I'm trying to keep this very brief because we have other things to do here. So this would be an example. Say this is a invader. These 6 organisms could be like Staph aureus. And let's say we get a staph infection. Well, what will happen is the circulating monocyte is going to recognize this as being genetically different. And so it knows that it's a threat. So immediately what it does, it's just like that animation showed, it releases a series of cytokines. The cytokines are things like interleukin-1, interleukin-6, tumor necrosis factor alpha, and tissue factor. These are all designed to do some things very specific. And let me show you what they'll do. And think about it. If you think about this, it makes perfect sense. If I have an invader like a bacteria or virus in my bloodstream, what do I want to do? Well, I want to contain it. And so one of the things when you look at the immune system response, the initial response will be to try and do things like contain it. So tissue factor, for example, which is one of the cytokines, they'll release and they're going to cause a clot to form. Factor 8A to 5A, 5A to thrombin, thrombin to fibrin, and we get a fibrin clot. That's wonderful because now we've trapped the invader. But this gets complicated because our body's own fibrinolytic mechanism doesn't like clots, so it's going to try and lyse this clot. So the cytokines do 2 more things. They're going to release things or activate things like TAFI and PI. TAFI is thrombin activatable fibrinolysis inhibitor, and PI is plasminogen activator inhibitor. These are both going to now suppress fibrinolysis, and that clot's going to stay there, which is wonderful because we need the clot to stay there till we kill these organisms. Now, the other thing that the cytokines are going to do, they're going to open up the capillary wall. So neutrophils, which you can see on the bottom of the illustration, are going to flood the area. And you might remember that neutrophil chasing bacteria. Now we're going to bring in millions of neutrophils, and they're going to chase all of the invaders until they catch them and kill them. The immune system is awesome in its ability to do this. Now, the other thing simultaneously, what's going to happen is we're going to start to take some of this information from the invader. The neutrophil is going to take this, for example, a T4 lymphocyte. It's going to take the information about the invader, go back to lymph nodes. Now they're going to start making an antibody. And the antibody is specific for that invader. And so in this case here, we would make an antibody for the Staph aureus. And so for the rest of our lives, if we see that Staph aureus again, our immune system will be ready for it because we've created an antibody for it. So this all is great. And then what will happen is once the invader is controlled, everything down regulates. We quit making cytokines. The clots now are able to be lysed and everything goes back to normal. This is what happens in us every day. We don't even know it. But here's the problem. When sepsis happens, this process doesn't stay localized. And I'll give an example. We had a 62-year-old gentleman who was admitted with bilateral hip replacement surgery, but he had infections in both hips. When he initially came into the hospital, he was tachycardic, he was running a fever, and he was having a little trouble breathing. Now, if you have a hip infection, you shouldn't have any of those. So what we were seeing, what are called signs of systemic inflammatory response syndrome. And this is when an infection starts to show it's going beyond the local area. And what happens in this situation here is the immune system has gone beyond just the local infection. Now, we've struggled to find a treatment for sepsis. This is an illustration of the sepsis graveyard of treatments, things that very smart scientists tried to use to try and find treatments for sepsis. And I was involved in several of these research studies. None of these worked. So we couldn't find a way that would slow down the immune system so that we'd be able to help people survive. And so when you look at one of the reasons COVID had such impact in nursing homes, well, if you have a comorbidity where your immune system isn't quite capable of responding like it normally would, it just puts a person even more at risk. And so COVID really decimated a lot of our nursing residents. And again, the reason being is we weren't quite able to help with the treatment. So we're still struggling. We're still desperately trying to find treatments for sepsis. I would love to say that we're close, but I can't really say that. So what we do now, and one of the responsibilities of everyone who works in a nursing facility, is to recognize sepsis. And I'll talk briefly about those signs. But the treatments we have, like I said, are really just supportive. We try and give fluids if a person's blood pressure is low. If they need to go on a ventilator, we can do that. We obviously give them appropriate antibiotics, but if it's a virus, the antibiotics won't work. And we don't have a lot of good viral therapies. So we're looking at trying prevention, and we can't emphasize prevention enough. Don't let people get infections. And, if you have somebody who's got a respiratory condition, make sure they've got a mask. If it's susceptible to a vaccine, make sure they've got a vaccine, because that's how we're going to stop sepsis. So the best thing from a nursing home staff member, and we mean every staff member, from CNAs to nurses, even non-clinicians, should recognize this. If someone has an infection of any kind, do they now have SIRS, or systemic inflammatory response syndrome? And all that means is their heart rate higher? Is their respiratory rate elevated? Do they have a fever? And do they change their behavior? A person with sepsis might have all of these. They could actually have none of them. And that's what makes sepsis so hard. But typically they'll have something along these lines. And so we built a program that's designed to try and help clinicians and staff members of nursing homes be ready to treat or to identify sepsis. And so that's really the whole point of a program that we are going to show. Are we ready to, I'm going to stop sharing just for a second. Do we have another speaker? Kirsten, are you here? We're here. I was worried. So I will turn that over to, I think you're on mute, and then it'll be all yours.
All right. Are you guys going to share my slides, or do I need to?
We could do either way, whichever you prefer.
I'll let you guys.
Okay, good. I do have them pulled up, so I can go ahead and
Perfect.
you just tell me when
Okay.
you would like me
Go
to
ahead and share, and I'll tell you when to move forward.
All
So,
right.
I'm Kirsten Akin. I am a nurse, and I'm also a sepsis survivor. And so this is my story from me personally, not my story from my work or anywhere that I work currently. Next slide. So before sepsis, who was I? I live in Wyoming. I've lived in Wyoming my entire life, and I am a Wyoming girl, true to form. Outdoor stuff, hunting, fishing, four-wheeling, camping, boating, all the things outdoors. My family is here. I am married. I have a daughter. I'm very close with my family, extended family, and my friends. Things that I have done in the past for jobs. I was a vet tech, embryo technologist for a cattle company, and then I became a nurse. So I have done med-surg, ICU, OR, case management, and utilization review nursing before sepsis. Next slide. So kind of a background of what happened. I had my daughter in 2001, and I'd had a lot of gallbladder issues while I was pregnant. So about 2 months after having her, I had quite a bit of pain, and for whatever reason, when that pain came on, it made my body have the response of passing out, or total loss of consciousness. So they decided to take my gallbladder out because we didn't want that happening, having a newborn at home, and my husband worked, so I was home by myself. So I had my gallbladder out in 2001. That was full of stones. They knew they had a few stones that they couldn't retrieve. So then in 2004, pain came back. They did a CAT scan, didn't show anything. So they went in to do an ERCP thinking one of those stones might be causing an issue again, and found nothing. But the pain stayed away for quite a while until January of 2020. I started having the pains again. That one we just kind of left as a one-off, but then when it happened in April of 2020, that's kind of when my nightmare started. Next slide. So in April, I had the pain, had my husband take me to the ER, and I'd already passed out at home a couple of times. They hooked me up to the monitor, and I can tell when I'm going to. So in my mind, I yelled for the nurse to come. This was the hospital where I worked at that time. So I yelled for my friend and coworker, and so I thought. And when I woke up, they were just about ready to give me chest compressions. I had flatlined for 16 seconds with no other than this pain, nothing else going on. So they decided that I could not work in the OR, that it was a safety risk for me and my patients, as long as I was having that vagal response. So I needed to get workup. So I did cardiac, wore a monitor forever, didn't find anything. They wanted me to go see neuro, but neuro said, I don't think it's a neurologic thing until we figure out why the pain is happening. We can't fix the neurologic response. So they didn't want to do anything. So then I went to GI. Next slide. So on May 18th of 2020, right when COVID is getting hot and heavy and all the hospitals are starting to worry about that, I went and had an ERCP at a bigger hospital about 90 miles away from home. Wyoming, we have tiny, small little critical access hospitals that don't do all of these things. So I went to a GI that I'd seen multiple times. He had done other ERCPs on me. Did the ERCP, he did a sphincterotomy to release a little bit of the pressure on my sphincter of Odie, cleaned a bunch of stuff, sludge out of there, and I was discharged home. My husband drove me home that night. He said, I don't remember any of this part. He said that I felt wrong right away. I told them in the outpatient setting, I felt wrong, that things weren't right. But doing that sphincterotomy, they felt like that's probably why, that it was probably spasming a little bit. I vomited on my way home, got home, apparently laid in the fetal position on the couch for a while, took a hot bath to try to relax, and just couldn't get comfortable. And finally, my husband at 6 o'clock at night said, I'm not going to do this all night. We're going to the ER. So we went to a small town critical access hospital. The ER doctor called the bigger town, and the doctor that did my ERCP happened to be the one that was on call. So he told him, it could be pancreatitis, which can happen. Let's go ahead, and if you admit her and she's not better by the morning, I want her back up here. So they did admit me to the hospital that night, and nobody ever contacted GI again. No, and they never even consulted another GI if mine wasn't on call. Next slide. So the first 2 days, that night I was admitted to the hospital. My labs were off, as they should be. CAT scans showed small amounts of free fluid, but that can also happen. So everything that was happening could have been pancreatitis, but also could have been something more deadly, like a perforation. Day 2, my pain was not controlled. My lab values were still abnormal, but they didn't consult anybody else. They didn't do another CAT scan or an ultrasound. Nurses kept telling them they thought my abdomen was growing. Nothing else was done other than pain meds. And then in the evening, I began to crash. Next slide. So my blood pressure tanked. I had to be on Levophed to help my blood pressure stabilize. For the pain control, I was on a continuous drip of ketamine, and it still wasn't controlled. So they called Life Flight, and they still did not ask the larger hospital for GI. They asked for general surgery. So GI still is not consulted again at this point. I was life flighted. I have had some flashbacks, which are really weird and scary, but I do remember telling the flight nurse that I could not breathe and they had a mask on me. And she said I was oxygenating fine, so I was fine. And I was tied down, but I tried to wiggle a little bit to get the mask moved because really the fluid in my abdomen that was building up was putting pressure on my lungs. So I did have the feeling that I was not able to breathe, even though on their monitor I looked fine. I knew that I was not good, apparently. And in this same flashback, I remember when they finally had the ER nurse at the bigger hospital, or the ER doctor at the bigger hospital, come in. I remember looking at her as she was putting the ultrasound on my abdomen, and I said, "Please don't let me die." And she started calling for medications that I knew I was getting intubated and rushed to the OR. Next slide. So this is kind of my stats. This is me and my daughter. I only have one kiddo. She was 13 when this happened, and 13-year-old girls, especially when they're the only kiddo, they need their moms. So I was intubated for 10 days, in ICU for 14 days. I was in that larger hospital for 61 straight days. And then I spent another 30 days at a smaller critical access and back in Wyoming as a swing bed patient. 55 days straight, I did not see my daughter other than on FaceTime. And that was probably the worst part of everything. We're very close. We're a very close family in general, but my daughter and I were very close and did a lot of things together. And because of COVID, they finally had to make an exception for her to come in. She was not allowed in the hospital because of COVID. So on my abdomen, they did a total of 16 surgeries, all in that 61 days in the larger hospital. They ended up, when they stopped being able to go through my abdomen because everything was getting too bound up with scar tissue, they had to go through my back to clean out infection, and did 2 surgeries there. Medical equipment, I laugh because I said I'd had every tube that you could have except for an NG tube, but I've now had an NG tube because I continue to have blockages. So I had central lines, art lines, G tube, J tube, a T tube, which helped drain my bile from the perforation of the bile duct, 3 drains for infection, a Dignacare drain to drain my stool, PICC line, Foley catheter, periwick catheter, wound vacs, epidurals for pain control, feeding pump, and an Aristus transfer mat. All of that was needed. And at this time, I was a 41-year-old, otherwise fairly healthy woman. Next slide. So this is a picture of me in the ICU with all the drips and everything. Next slide. There is this is a Diphthera vac, wound vac. So they put this wound vac on. Underneath that blue foam is my intestines. There's nothing else there. And my family laughed because every time they would take me into surgery, they would say, "We hope to close her this time." And so when my family was hearing that, they were thinking, like a little inch maybe. And then when they finally see this, every time they'd say, "We hope to close her this time," they couldn't comprehend how they thought they were going to close this massive gaping hole in my abdomen, because everything was so swollen inside that once they opened me up, they could not close my tissue back over it. Next slide. In the ICU, and I was an ICU nurse, and I had no idea that this happened. None of my patients ever told me this. I had horrible delusions. My perception of what was happening and what they thought my perception was were not lining up. They thought that I knew what was going on because when they would ask me questions, I would answer appropriately to them. In my head, though, that is not what was happening. The images in my head, I thought people had died. I thought I was had a trach and was never leaving a wheelchair and never going to be able to talk. No one would let me see my daughter in my delusions. They were sharing medical equipment with me and other sick people in them. They were very traumatic. and they never stopped. They just kept going and changing. I never felt like I was sleeping. And I was getting very agitated at times because I was very hot. I always wanted them to pack me in ice. And it took usually quite a while for them to realize when I'd get agitated that that's what I wanted. I had one horrible nurse. When they finally extubated me, I was so weak, I could not even hold a plastic spoon or push a call button. And that nurse decided that I didn't need suctioned more than like a couple times that night, didn't look in my mouth to know that I had a massive amount of thrush, but my tongue was sticking to the roof of my mouth and I could not even push a button to call or get suctioned. And so that really made me realize as a nurse, sometimes those little things do matter. And I was amazed at how weak I'd become in that 10 days. I finally got to see my family. For some weird reason, I could not visualize anybody. It was just the delusions until after they'd extubated me. I don't know if it was the medications or what, but finally, when I was extubated after a few hours, I could see their faces and actually started to come back around. First time out of bed, so they told me they were discharging me from the ICU, and I said, "You're not discharging me from the ICU if I can't get out of this bed." So they called PT and OT down, and they ended up being friends of mine that I had worked with when I was in the ICU. And they were my angels. They, it was a lot to move me. It was a lot of equipment, and they made sure that, if I wanted to get up, that we were going to get me up and get me out. Through all this as well, my family had been asking the surgeons, "Hey, did anybody contact that GI doctor? Does he know?" And he works in the same hospital. So we were surprised we had not had him on the team or had him come in. And the last day I'm in the ICU, he walks in my room and he's kind of white in the face. And he almost starts to cry. And he says, "Kirsten, I had no clue you were here." He had found out that day. I'd been there for 14 days and almost died. He felt horrible. We let him know that we had asked multiple times if he had been consulted. And like I said, I'd seen him before. We had known, I'd been a patient of his for years. I wasn't just a one time, so we had a relationship, and he kept coming in. Next slide. He kept coming in and visiting me throughout, and he laughs because at one point I told him he had to stop apologizing. I 100% feel like if he knew he had perforated my common bile duct, he would have fixed it. He obviously did not know. So then I get moved to the surgical floor. No more ICU. I was all excited. They put me in this tiny, tiny room, and there's no bed or no window, and I'm still too weak to do anything. And somehow that first night, they wouldn't let my family stay during the night. That first night, I ended up at the bottom of the bed, no call light, freaking out because A, I can't move, and B, I'm going to surgery the next morning. And I had this traveling nurse, and his name was Herman, and he was such a grounding blessing. He made my night tolerable. I had him quite a bit. When you spend 61 days there, you end up with the same nurses quite a bit. So he did quite a bit to help me with my mental journey through this. He just was a very grounding spirit. Then they just kept saying, I'd wake up, "Did you close me yet?" "No, we didn't." And I'd look down and I'm like, "It's no smaller." So finally they decided, A, that I had too much stuff with me, so they were going to move me to a bigger room, and B, that we could not go back into my abdomen. So they put in some mesh, and we started a wound vac and let my body heal itself. I had a decent view with this room. It was big enough. I had tons of flowers and things that people had sent, so I could have all that set up, and my family had a comfortable place to sit because I was lucky enough to have family or friends that came and spent the entire day with me every day I was there. I was never alone during the day. Some other amazing people. I have a nurse named Keegan. We used to joke that she needed to sneak her cats in because I was missing my animals. Britton was my wound care nurse. He was amazing. I still keep in touch with him on Facebook. Diane was a night CNA, and on nights that I had some pretty good delusions or hallucinations, she'd come sit with me if she wasn't too busy. Carly and Aaron were the PTs. Dawn C, she was a doctor who finally came in and realized that my team was huge, but they were not talking. And this became a really big issue with all the infection that I had. And so she helped a lot to try to get my team to talk. It never really came to fruition. If they had talked with me as a group, if we could have had a big powwow, I would have made decisions differently and probably would not have possibly been in the hospital as long. And that was all related to do we operate through the back? Infectious disease wanted to do that way earlier than we did, but general surgery was worried they would have to remove ribs. And at that point, I couldn't lay on my side or my belly because I'm still open. And if they've removed a rib from my back, they were worried that I would have no position essentially that I could lay in. But once they finally looked closer, they decided they could do it. The other dilemma that we ran into was nutrition, and they didn't have GI on there. And the surgeons didn't really want to progress things as quickly as the nutritionists thought. And I was not tolerating the tube feedings. They had me on TPN for quite a while. Other things, when you float nurses to different levels, probably don't give them a patient that has all these things. I actually was teaching nurses how to manage my drains, how to do a feeding pump. And we laugh, and I used to think I became a nurse to help people, and now I'm wondering if it wasn't to help myself. Next slide. So big things to remember are just that you need an advocate. Whether it be your family because you can't, a friend, or yourself, you have to have an advocate. So these are pictures of my first dressing change. They were Mondays, Wednesdays, and Fridays, and they were horribly painful. All along the edge, that top, right, the skin, that raw edge, that was all nerve endings. And they would have to give me Dilaudid for the pain to get through the removal of the dressing. And I will tell you, I hated the way it made me feel, but I can see how people get addicted to it because it does, your brain craves it. It is the weirdest, scariest thing. Next slide. So this kind of shows a little progression of things healing up. And it was so cool to be able to look down and see those little red bubbles of cells and tissue starting to form. Next slide. And my friends and family enjoyed it too. So I had some amazing friends, and they came and stayed with me to give my family a break. And the friend in this picture, she took an electric razor and shaved my legs and my armpits and painted my toes and trimmed them, because those are things that you don't think about. Nobody thinks about when you're in the hospital that long. And a lot of the time it was my dad staying with me, and I really didn't feel like he probably wanted to shave my legs and my armpits. So this is just one of my friends that had come and stayed with me. And then these are some of the nurses and the therapists that became friends throughout this. Next slide. And this is my husband and my daughter on the 4th of July, and my dad and I on the 4th of July. He went and found the only red, white, and blue thing he could find, which was a towel that had fish on it. But so this is just kind of a picture to show what I missed. Next slide. These are the images from my back surgery. So they went in one day and then they waited for 2 days and went in again. And so they only tacked it together with those two little sutures. And the pain involved in this, I got in a major pain crisis. My blood pressure lowered, and so they were lowering the epidural, and the pain was, I asked at this point if they would let me die, and they informed me I was not dying anymore. So they would have to kill me, and they were not going to do that. The pain was unbearable. Finally, we got the anesthesiologist up there, and he helped us get it fixed. But again, it was another communication thing. The nurses were doing what they could, but it wasn't getting relayed like they were being told to the whole team. Next slide. This kind of just goes through that. So, big thing is, once again, we're right at the lack of communication. The reason that would not come out of the drains they had in me is the rest of the pus, or whatever you want to call it, the gunk left in there was as thick as toothpaste. So my drains were not able to pull it out. Next slide. So things that I missed. My daughter Haley's first softball season as the starting pitcher. I thought I'd be great because I could watch it on FaceTime because technology is amazing. But it turns out I wasn't great. I cried the entire game on FaceTime. I remember the nurse came to come in and saw me crying and went out to finish my evening stuff later. My daughter and my mom went out to see my sister in California and my niece, and I'd only been able to see my niece once. Haley got to ride and jump horses. I had a very close friend that died, and I did not get to attend their funeral. Haley got to go hunting for the first time. That was hard. I was home by then, but I couldn't physically go. And those are some of my most cherished memories with my family, are growing up hunting together and learning to hunt, and all of those times that we spent. And I missed her second season as well because I still wasn't physically able to go. My family and friends put together a benefit for me to raise some money to try to help us. And I was still in the hospital at that time. My best friend's twins, who are more like nieces to me, they graduated high school. I missed being fired from my job on the day they actually fired me. Even though I was in their hospital as a swing bed, they came in and told me 2 weeks later because I ran out of FMLA. Countless opportunities to enjoy my life, family, friends, and doing the things that we love. And then recently, 4 weeks ago, I had another bowel blockage and ended up in the hospital. So this nightmare hasn't ended for me. This is the second time I've ended up in the hospital with a blockage. I've had 2 others that I just stayed home and managed through the pain. They still make me pass out. It's still horrible. Now it's at the place they had to do a little bit of a resection, and I'll get to that later, but it's in that area. So I continue to miss out. I missed out on my niece and nephew with their first show. They showed goats at fair. I missed out on that. And I, missed out on those days of family spending time together. Next slide. So I came to swing bed, and then I went home health. You can see this picture kind of in the center that has the white with all those tubes. So I had 6 tubes from me. On my left side, I had a tube going into my stomach and 1 going into my intestines. And then on my right side, I had 4 different drains that were draining infection. And then the one of those 4 was the one that was draining the bile. Getting back home, I would not have been able to do that had I not had connections. I was very complex. They considered me still, so they did not want to take me back. But I assured them that I knew what my care needed to be done. I just needed hands to do it. We were able, because of COVID, this is my family by the truck. They would wheel me out in a wheelchair, and they would let us be together outside. So my mom would cook dinner every night and bring picnic tables, and that's me and my niece and my sister and my dad and my grandpa. So I still got to interact with them. And then my window opened outside. So during the day, I'd have visitors come and knock on my window, and then I'd get to visit my friends and family that way. After 91 days, I went home, and I still had daily wound care, whether it be home health, going into the hospital, any of those things. Next slide. They managed to make me have a babysitter, and I or my family managed those 6 tubes for another couple months. What I gained from this, appreciation for life, family, friends, strangers. I'm definitely closer to God. I believe in the power of prayer. I should not have lived. I've been told by many people. I was humbled by my community and how they reached out in so many ways. I do feel like I'm a better person all around, and I know that it helped me be a better nurse. And I wouldn't have been able to have all that time that I was out of work for those 2 years that I did get to spend with my family and be with them every day. Next slide. So these are just some pictures of fun things after that I was sick. That blue Jeep that you can see where my daughter's petting the dog, we bought that when I was discharged, the day after I was discharged from swing bed. and it was my therapy goal. I had to use a stool to get into it, and I had to be off pain meds and be able to get in it by myself to drive it. So that's what my husband got to keep me moving at home. Next slide. And this is just some progressive pictures of in November of 2020, I had a skin graft because my abdomen was growing great, didn't need a wound vac anymore, but it was just going to take a long time. So we did that surgery. Next slide. This is the progression of how the hernia ended up. You can see the bumps, that's my intestines, and it just kept getting bigger. That skin just kept stretching. Next slide. So at the hospital close to home, they told me this could never be done, and I was not okay. They told me I was their most difficult patient, and the patients that live that should have died, medicine's not ready for, and I did not accept that. I asked my primary care doctor to send my stuff to Mayo, and Mayo was my savior. They went in and dissected everything back down, pulled all of my muscle layers, all the layers apart, took about a bunch of adhesions, took out that 6 centimeters of small bowel that was adhered to my abdominal wall. I spent 3 days in the hospital, missed some stuff still, but my best parents ever were with me the whole way. Had to stay for a couple of weeks in surgery or in Arizona after surgery, and then I got to come home with a relatively flat stomach again. And we used to laugh. My belly button went back, but we laughed that they left it before because it was like, I'd say it was in left field. But in here, since they were able to put me back together, they got it back centered. So next slide. You know, I'm still the same person, but I've changed a lot. I still love going and watching my daughter. I still do my best. I'm weak. I don't have the stamina. I still have PTSD. I still have pain daily and the fear of being put back in the hospital. While I'm sad for what I've lost, I'm also grateful that I've gained the ability to still be here, because when you're faced with the decision of you either live or you die and you deal with it, you know, I'll always choose to live. So now this has changed. I've now had 2 hospitalizations for that small bowel obstruction. I still work. It's a struggle. But I do work full time, so I was able to come back. But I do still have flashbacks. Next slide.
That is the last slide.
Oh, perfect. Okay. So that's my story. And I will let Tom take back over.
I think, yeah, I'm gonna go ahead. First of all, Kirsten, thank you so much for sharing your story. Every time I hear it, it just gets more and more powerful. It's just kind of a makes everybody open their eyes that sepsis can happen to anybody. You know, we're all healthcare providers. We're all taking care of residents, patients, but at the same time, it can happen to anyone. So that's what our program is with Viven Health. Is we want to emphasize the importance of prevention. So if it's okay, Catherine, I'm just going to take 1 minute just to show our program briefly, to give everyone a solution to sepsis. And I'll just literally take a minute. I just want to make sure everybody is aware. So I know you all have received emails from me in the past, just kind of telling you about our programs that we offer with Viven Health. These are all free programs to you, available at no cost on behalf of Quality Insights. The newest programs we have right now are on sepsis prevention and enhanced barrier precautions. You also have the vaccination and infection prevention program that are available too. Now, all of these different programs all help with the prevention of sepsis because any infection can turn into sepsis, as Kirsten mentioned with her story. So I'm just going to briefly show you what our education modules look like. We at Viven Health are all about doing. We're all about teaching in an interactive way that is engaging yet effective. So with our program for sepsis, you're going to go through different interactive scenarios and learn how to identify what sepsis is and what to do. So instead of just telling someone, you know, the importance of checking vital signs, they're going to do it with our program. So first, we're going to check pulse. Now, another thing that Kirsten mentioned in her story that was very important is communication. I know communication is everything, and sometimes it feels like our voice is not heard, but we see through Kirsten the importance of really emphasizing our voice and making sure it's heard. So not only do we teach about that, we have an interactive scenario where you go through a scenario where you have to learn how to communicate with the doctor. Next, we're going to check the temperature. And everything you're seeing here right now, it's not a video. This is actually me doing. Now, this is what sets our program apart from other learning experiences, is that interactivity. Not only does the interactivity make it more fun and engaging, it's also scientifically proven to be more effective and it result in behavior change. So this program is available to your facilities at no cost, doesn't cost you anything at all. To get started, all you have to do is just simply scan a QR code and share a flyer. Catherine has those for you all, and I'm sure she'll put them in the chat for you all to access them. If you would have any questions at any time, feel free to email me and let me know. I'm always here to help as well. But just wanted to kind of give you a brief overview of our program and just demonstrate the interactivity. Our whole goal here is to really make a difference in sepsis prevention in your facilities. And just the FYI, September is Sepsis Awareness Month. So it is the perfect opportunity to get this program launched in your facilities and get your staff members on board. Anybody have any questions on that part? No? Okay, and then I'm going to show one last thing here. Can you see my slide, Catherine? With
We're
the
still
QR
seeing
code?
we're still seeing the dashboard.
Okay, all right, let me just tap here. I'm going to just briefly show you all just a QR code if you want to go ahead and just get signed on now. All you need to do is just get your cell phone out, scan this QR code, and it will take you directly into the program. As I said, Catherine will also send you all the flyer with the QR code to get you started. And please reach out if you have any questions or concerns. And thank you all so much for allowing us to talk. And thank you, Kirsten and Tom, as well, and Quality Insights.
Absolutely.
So I'll
Thank you,
just keep this on,
Natasha.
Catherine.
Thank you, Natasha. Thank you, Tom. And thank you, Kirsten. That was harrowing. Thank you for sharing your story with us. And there's lots of comments here in the chat saying thank you as well. And Natasha, someone did comment in the Q&A that said, I keep trying to train my nurses on how to be proactive, and this really looks like it'll be an easier training to understand. So thank you for sharing that with us. Hope you can get this program and share it with your coworkers and your colleagues.
Great.
If anyone else has a question, please submit it at this time using either the chat or the Q&A tool, or you could also raise your hand if you would like to ask your question out loud. We have just about 5 minutes left before we should sign off here. While we're waiting, I'd again like to invite everybody to next week's webinar, which is on best practices for respiratory virus season. That will be next Wednesday at 2 p.m. We also invite you to bring your questions to our live chats every Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to our live chats and our webinars in the newsletter we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at ccaudell@qualityinsights.org. And I will get you on that list. And I will drop my email in the chat. I also drop Natasha's in the chat. If anyone has any trouble trying to get into the portal, just give her an email and she can help you, especially if you don't see your facility on there, although I would hope we have them all in there by now. Let's see, someone said, thank you for sharing your story. Learning through story stays with people and helps them relate to what they see and with what they've heard. It's so true. And I was also going to mention, as I'm emailing everybody later this week, the presentation slides and of course the flyer and how to get into this training, I will have the link to the recording as well. So if anybody wants to share the link to the recording with their colleagues to get them interested, to let them know, you can share the video with them. Let's see the Q&A. Someone says, our staff is not allowed to carry cell phones. Is there another way to access the training program? Yes, there's a direct link on that flyer. And I also dropped that link in the chat. And if you have any trouble with that link, just email me or email Natasha and let us know. If you look at it, it says, and I'll drop it in again, it says vivenhealth.com/corporations/quality. So that'll take you to the same page that the QR code does. Are there any other questions before we wrap up? And Natasha, Tom, Kirsten, is there anything you'd like to add before we close out today?
I just want to add one thing. Just remember that not only is the sepsis program available to you, also the enhanced spirit precaution program, infection prevention, and vaccinations.
Kathy, you're on mute.
Thank you, Tom. We have flyers for those too. If anyone's interested in that infection control training, I think that link takes people straight to that training too. Is that correct, Natasha? They can find it all there.
Yeah. Yes, ma'am.
All right. Well, I think since we're not having any more questions, I'll go ahead and wrap us up. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Natasha, Tom, and Kirsten, I'd like to thank all of you for joining us today, for the demonstration, for your stories, and the education. I'd like to thank everybody here for joining us today and hope to see you again soon.
Thanks so much. Appreciate your opportunity.
Thank you.
Thank you. Bye-bye.
Thank you for allowing me to speak.
Thank you so much, Kirsten. All right, everybody, have a good day.